need some cheesy garlic bread. Now,
नहीं
चाय के साथ गरम-गरम
नहीं अभी मैं कोई एक ग्लास सारा पानी दे देगा तो बहुत अच्छा रहेगा.
आ जाओ खाने के लिए.
नहीं चाहिए. In the middle of lecture, I don't want this.
Good evening, Zamir. Hi, Zamir. Good evening.
Hi, Sri Krishna. Hi, how are you? How are you?
I'm fine, thank you.
What's up?
Just waiting.
Is work started full swing?
Work, yeah, to a certain extent, yes.
You're traveling every day.
Well, it is a travel, yes.
It
I
is
go
1
up
hour away, isn't it? You're saying 1 hour or so.
1.5 hours, yes.
Oh my God, oh my God. It's so
I'm
difficult.
almost
Yeah,
going to Tamil Nadu every day.
yeah, it's so difficult. 1 hour is a lot, actually. Okay, so we've got everybody in. So I'll start talking about. Have we got this guy? What's his name? Vikas, are you with us?
Yes, sir. I'm there, sir.
Vikas, take over. I'll start recording, and then you take
Yes, sir.
over as a.
Yes, sir.
Yeah, 1 minute. Yes, where is the recording button? I can't seem to find it. Record on this computer. Okay, and I will just quickly make you the. A lot of people waiting actually. So Vikas is here. So Vikas, are you host now?
Yes, sir.
Okay, so you take over. People are trying to log in and things like that.
Yes, sir.
But
Yes, sir.
also at the same time, you concentrate on writing your answers. Okay, it's quite important.
Yes, sir. Yes, sir.
So, okay, so I think today's session is actually designed for the younger surgeons. I don't think there's anything new to learn here, but it is all an MCQ. It's not MCQ actually, it's flashcards. So what I've done is I've got about 200 plus eponyms. Eponyms means any procedure, any test, anything that's named after a surgeon. Okay, so it has got a, not a surgeon, but it has got a name attached to it. Okay, so I have got individual stuff, and I will flash you the slide. I want you to make 3 columns on your book. On one a small column where you write the number of the slide. So 1, 2, 3, 4, 5, 6, 7, 8. It will probably go to 200, I think. And then leave a large column in the middle where I want you to write the answer to the slide. And some questions will also have 1 or 2 additional points. Okay. So I'll ask you additional points. So this is all quick revision for exam going people. And the third column is where you write your mark. Okay. And the mark is 1 mark if you get the whole question right. So some questions will have either just the name of the procedure or some question will have give 1 or 2 points about the procedure. Okay. So I will share everything with you as we go along. So this is a very, very interactive thing. I don't want you to talk on it because otherwise it will become chaotic. I want you to write down your answer and you mark yourself. Okay. And anybody has got any questions you want me to stop, pause, you can actually switch on your microphone and ask me something more. Okay. But as far as possible, we'll try and keep it an one-on-one session. So everybody whom I'm talking to must have a notebook with him and must have, pen and pencil. You must write everything down and be fair with yourself. Don't give yourself mark if you don't deserve it. Okay, so just be fair with yourself. Don't cheat. Because at the end of the day, it is your learning process and your examination that you have to learn. Okay, so, okay, let's start with the first one. Okay, this is an image of a pathology which happens in the esophagus, usually seen in the lower esophageal sphincter, around the lower 1/3 of the esophagus. Give me the name of the pathology. I want a name. This is usually not transmural. Not transmural. And I'll give you 10 seconds to write down. Okay, so you have time to think. And then I'll carry on and we will then give you 1 or 2 salient points about each one. So what is that blue square? Give me a name of that pathology. Okay. And somebody just say okay, and I will continue to the next step. Because you can take over, or somebody, Bhushan is there, he can say.
Okay.
All right. The answer to this is Mallory-Weiss syndrome. Now, I want you to, before giving yourself the whole point, I want you to give me 2 or 3 points about Mallory-Weiss syndrome. Give me 3 points that you can think about Mallory-Weiss syndrome. If I ask you in a Viva, describe Mallory-Weiss syndrome, give me 3 points. Write them quickly. Okay, 10 seconds and then we'll carry on. Okay, so the important points are, it's a partial thickness rupture, usually around the GE junction, usually below the GE junction in the gastric cardia. Only a few tears involve the GE junction itself. Tears only involve the submucosa and the mucosa, but not the muscular layer. Okay, if you haven't got these 2 words in, you have to deduct half a mark. Okay, otherwise it's not a valid answer. The other type of tear that you can see in the similar situation is Boerhaave syndrome, where the tear is full thickness. So you must remember that Mallory-Weiss is partial thickness, Boerhaave is full thickness through the esophagus. And usually Mallory-Weiss does not cause spillage, whereas Boerhaave causes spillage into the mediastinum. Okay. Mallory-Weiss syndrome is seen in alcoholics, in patients who abuse analgesics, in pregnant females, and patients with hiatus hernia. Everybody happy?
Yes, sir. Yes.
Yes, sir.
Okay. Now I'm going to give you 2 points. You have to tell me what this is. This graphically displays the survival of a sample cohort. The survival estimates are recalculated whenever there is a death. What is this? Don't tell me the answer loudly. You write the answer yourself. So graphically displays the survival of a sample cohort. The survival estimates are recalculated whenever there is a death. What am I talking about? Okay. Happy?
Yes, sir.
Yes.
Okay. It's a Kaplan-Meier survival plot. Okay. That's what we're talking about. Okay. This is an artery which goes to the back, an abnormal pathway which goes behind the esophagus. What is the symptom called as? This artery is an abnormal artery which arises from the arch of the aorta and goes behind the esophagus. But what is the symptom called as? What is the name of the symptom?
Done.
Okay, dysphagia luceri. Okay, all right. So dysphagia luceri is usually because of compression of an aberrant blood vessel upon the esophagus, and it causes dysphagia. Okay, what is the other name for this dysphagia? There's another half mark for you, or extra 1 mark for you. What is the other name for this dysphagia? Who described it? Okay, it's called as Bayford-Autenrieth dysphagia. Okay, so dysphagia luceri, the actual name is actually described in literature as Bayford-Autenrieth dysphagia. Okay, they are the first guys who described this dysphagia. Yeah. Okay. Usually present in the esophagus, causes symptoms of swallowing. May be complete or incomplete. Give me a diagnosis. Whenever you finish, say yes. I'll move on to the answer.
Yes, sir.
Yes.
Okay, this is a Schatzki's ring. Okay. All right. So Schatzki's ring is usually a mucosal ring at squamo-columnar junction of the esophagus and the stomach. And the commonest symptom is dysphagia. Okay. Happy?
Yes, sir.
Okay. This is an accurate test for association between categorical variables. An accurate test for association between categorical variables. What is this test called? Usually used for small samples. When the sample is less than 10, usually you use this test. Okay?
Done.
Fisher's exact test. Okay, that's what it's called as. Look at the next picture, and I want you to identify the name of the operation that is going on. Identify the name of the operation. What is going on in front of you? And the second thing I want you to tell me is in what condition do you do this operation? So 2 questions in this.
Yes, sir.
Okay, this is Heller's myotomy. Okay, I'm sorry, the spelling has got reversed. It's Heller's myotomy, usually done in achalasia. Okay, so Heller's operation is an operation done for achalasia cardia. There may be a deformity, radiological deformity, which is called as pencil tip deformity, which is seen in achalasia cardia. Okay, give me a name. There are 2 names, and I need both the names for this. Give me a name, 2 names, and both the names I want. If you can only name one, then you get half a mark. Okay? Is everybody following? Is it making sense?
Yes.
Yes, sir. Yes, sir.
Is it education?
Yes, sir.
Yes, yes.
Definitely, sir.
Okay, give me a name, 2 names for this condition. Yes or no? Tell me when you want me to go ahead.
Yes, sir. Proceed.
Yes, sir.
Okay, this is Virchow's note or Troisier's note. Okay. So tell me about the Troisier's sign. What does it stand for? I just showed you the node. What does it represent? I'll go back if you want. This Troisier's node, but what does it represent? Or Troisier's sign or Virchow's nodes? In what clinical condition will you find that?
Proceed.
Tell me. Can I go ahead?
Yes.
Yes, sir.
Okay, it's left supraclavicular lymph node enlargement, usually found in cancer of the stomach. Okay, commonest sign. Cancer of the stomach with left supraclavicular lymph node involvement is called as Virchow's node or Troisier's sign. Okay, next question coming up. Okay, it's a test which is not dependent on the distribution shape of the data. Name the test or name the group of tests. A test which is not dependent on the distribution or the shape of the data.
sir.
Yes, sir. Go
Yes,
ahead.
sir. Yes, sir.
Called a non-parametric test. Okay, non-parametric test is the definition. This is the definition of a non-parametric test. Okay, all right. What are you seeing? What structure are you seeing, and what is happening? You have to tell me too. You have to give me the name of this, and you have to tell me what is happening. What is the pathology there? What is the change in pathology? I want to know the change in pathology. You get a full mark only if you answer both parts of the question. What is the
Yes, sir.
pathology? Okay, that's Barrett's esophagus. Okay, all right. So Barrett's esophagus is usually seen in gastroesophageal reflux disease. The lower esophageal epithelium undergoes metaplasia. The word I was looking for was metaplasia to intestinal epithelium. Okay, it is a pre-malignant condition. That's the other thing you should have written in your notes. Okay, it's a pre-malignant condition, usually pre-malignant to adenocarcinoma. It has high incidence in males. Okay, usually may cause strictures and ulcers. Medical treatment is useful only to reduce symptoms, but cannot reverse the condition. May present as a patchy or a ring involvement, and endoscopy is the main diagnosis. Okay, biopsy and endoscopy confirms the diagnosis, and the answer is metaplasia. Okay, so you have to use the word metaplasia. So Barrett's esophagus is esophageal stricture and epithelial metaplasia from squamous epithelium to a specialized columnar epithelium with intestinal metaplasia in 10% of severe GERD, and it is pre-malignant condition and predisposes to adenocarcinoma. Okay, name the test. Don't answer on this, please. Don't answer loud. You're supposed to write down the answer. Otherwise, it makes no sense to do this. We've got 40-50 people logged on. Name the test. And why do you do this test? So one is you have to give the name, and number two, you have to tell me why you do this test. Okay, this is Allen's test. Okay?
Yes, sir.
And Allen's test is done to test the integrity of the palmar arch. Okay, the arterial integrity. Okay, all right. Name the test. There are two names I'm looking for. Two names, and why do you do it? Why do you do it is written on the slide, but you must understand why you do it. Name the test. The three important things is reduction in the size of the swelling, disappearance of bruit, and fall in a pulse rate. What is this test called as? What is the eponym of this test? That blue mark, which I have covered up, is the name of the test. Yes or no? I have covered thoracic, I've covered cardiac, and I've covered peripheral vascular as well. Okay. So
Yes,
a
sir.
lot of things are related to all these topics. Shall I continue?
Yes, sir.
Yes, sir.
Okay, this test is called as Nicola-Doni or Branham's test. Okay, named after two physicians, Dr. Nicola-Doni in 1875 and Dr. Branham in 1890. Both of them describe this. And the important thing is it is done for arteriovenous fistulas when you suspect them, pressure on an artery proximal to the fistula causes swelling to diminish in size, causes thrill or bruit to cease, and the pulse rate to fall. There are three things which have to be described in this test, and the pulse to come back to normal. Okay, so this is what it is. So transient AVF occlusion causes increase in BP due to rise in SVR. Arterial baroreceptors get activated by the rise in blood pressure. It increases the vagal activity and decreases the sympathetic nervous system activity and may cause bradycardia. That is the Nicola-Doni-Branham sign. Okay, all right. Okay, next question. If the patient has the disease, you need to know how often the test will be positive. So this is positive in disease. What am I describing?
Yes, sir.
Okay, I'm describing sensitivity. Okay, sensitivity of a disease. Okay, what is the blue arrow, blue mark?
Yes, sir.
Okay, it's the Kunz nerve. Okay, and you got to tell me one more line about the Kunz nerve. What is the importance of the Kunz nerve? So I'll stop and write down one more line. Why do you need to know the Kunz nerve?
Okay, sir.
Okay, Kunz nerve was actually described for the first intrathoracic branch. Okay, so Kunz actually described only the first one, which is the collateral. But it is important to know this landmark because of cervicodorsal sympathectomy, because there can be recurrence if you don't cut the Kunz nerve. Okay, so it's very important. And it's not that it just comes in straight as a circle. There are 4 or 5 variations of the Kunz nerve. So this is your sympathetic chain. These are the sympathetic ganglion, and these are the intercostal nerves which are coming all along. So the Kunz nerve can come directly from intercostal to intercostal, from a sub branch to intercostal. It can have this orientation from a sympathetic ganglion to the intercostal, or it can have from the intercostal to the sympathetic ganglion. These 4 variations are important to know, because when you're doing a sympathectomy, your cut should be wide enough to include any of these variations. So you have to be careful the way you make the cut on the rib. Your cut must include all these variations in a single cut. Okay, so very important to know these 4 variations of a Kunz nerve. Okay, what is the picture? What is it called as, and what is the significance? What investigation are you seeing next to the picture? And why do you need to do the investigation? Give me the name of this, what you're seeing.
Yes, sir.
Okay, so this is a dumbbell tumor. What investigation was done? Was an MRI. Okay, usually done in the case of posterior mediastinal tumors, usually neurofibromas. So this is one of the few indications of use of MRI in thoracic surgery. The other indications are at thoracic outlet syndromes, where you need to see for neurovascular involvement. And also now MRI has been prescribed for small thymomas less than 1 centimeter. The follow-up should be done with an MRI. Okay, and also in mediastinal tumors, when you want to look for vascular invasion, MRI is a very sensitive tool. So these are 2 or 3 investigations where MRI is needed. Otherwise, you don't need an MRI in thoracic surgery. What is this sign called as? Give me a name to the sign. And in what clinical condition do you elicit this sign? Yes, no, okay. Hello,
Yeah, done.
Yes, sir.
can you hear me? Okay. This is the curse sign. It's called as the curse sign, okay? And curse sign is pain in the left shoulder because of irritation of the diaphragm referred via the phrenic, secondary to a hemoperitoneum, specifically rupture of spleen, okay? So specifically it's seen in rupture of spleen. So this is the sign. Curse sign, K-E-H-R apostrophe S. Okay, pause. How are we doing so far?
Excellent.
Very good, sir.
Going good, sir.
Going good. Are you getting right or are you getting more wrong?
All right.
Both. Okay, 50-50. Is it educational? It's a new way
Yes.
I'm trying to teach you guys,
Yes, yes.
because a picture says 1,000 words. That's why I'm trying to teach you in a different way. Okay, it's never been done before, eponyms in cardiothoracic surgery, but here you are. Describe the disease or describe the fibers. This square mark is the fibers. What is happening here on this picture?
Yes, sir.
Okay, this is Lenagore's disease, okay? Lenagore's disease is sclerodegenerative disease of the conduction system, particularly when it involves the right bundle branch and the left anterior fascicles in people over 50, okay? And it is associated with slow progression to complete heart block, okay? Lenagore's disease, you must know this. Okay, now there are 3 types of arrows here. There is a white arrow with a dash at the top. There is a white arrow on the side, and there are black arrow marks, arrowheads. So these white arrowheads, black arrowheads, and white arrow. I want you to describe each one. There are 3 questions here. What is the first one? One with the arrow. Second one is a white arrowhead, and third one is a black arrowhead. So arrow, arrowhead, arrowhead. What is happening on this chest X-ray? What are you seeing?
Okay, sir.
These are called as Curly's line, okay? The question is not yet finished. What is Curly's A line? I want you to describe to me what is Curly's A line. You get 1 mark. And second thing you have to describe is in which condition do you get Curly's A line? So what is Curly's A line? And in which condition do you get Curly A lines? Yeah or no? Hello?
Yes, sir.
Okay. Curly's A line is seen in pulmonary edema. Okay. It's a thin, non-branching line, several inches in length, radiating from the hyla, but not following the course of the vessel or the airway. And it is attributed to thickening of the connective tissue sheets, which contain communicating perivenous and bronchoarterial lymphatics. So Curly A lines happen due to lymphatics, not due to blood vessels, not due to airways. Okay, all right. So 1 mark if you got at least 2 of these lines right. Next question. What is Curly's B line? At least 2 points you have to write. I don't mind 2 small points, but just mention 2 points about Curly B line. And what causes curly B line? We said curly A line is because of lymphatics. What causes curly B line? Yes, no, okay, not okay.
Yes, sir.
Carry on.
Yes, sir.
Yes, sir.
Okay, these are small horizontal peripheral straight lines demonstrated at lung bases that represent thickened interlobular septa. So these are thickened interlobular septa. They represent edema of the interlobular septa. So A lines are lymphatics, B lines are interlobular septa. Though not specific, they frequently imply left ventricular failure. If you see curly, they're also present in pulmonary edema, but predominantly in left ventricular failure is when you see Curly's B lines. Okay, so A lines is because of lymphatics, B lines are interlobular septa. The next question is, what is this? Curly C line. Write down the answer, please, because that's the only way you'll remember these things. And as I'm giving you the answer, make your corrections as well on your notebook. Anybody knows what is curly C lines and why are they caused? Clinical condition in which you see curly C lines. You have to tell me yes to move on, okay? Otherwise, I'll wait.
Yes, sir.
Is everybody happy? Okay.
We don't know the
Curly
answer.
That's okay. If you don't know, leave a blank. That's okay. So curly C lines are reticular opacity at the lung base. They are Curly's B lines, but end on. So Curly's B lines are horizontal lines. Curly C lines are end on curly B lines. Okay. So that is why the black arrow that you saw was curly C lines. The black arrowhead you saw was curly C lines. The white arrowhead that you saw was Curly's B lines. And the white arrows that you saw was Curly's A lines. I'll go back to that in a minute. So this is seen in pulmonary edema or also in left ventricular failure. They are fine interlacing lines throughout the lung, which give you an appearance of spider web. Okay. They are actually head-on curly B lines. Okay. So they are nothing different from curly B lines. And they also represent interlobar septae. So when the chest X-ray is taken, some things that come horizontally are B lines, and what comes head-on through the cut section, because it's a 3D appearance, 2D appearance of a 3D structure. So that's why it's called a C line. Let me just quickly go back to that X-ray again and look at it again, okay? Okay. A line, B line, and C line, okay? So the arrow that you're seeing, the whole arrow is A lines. The white arrowhead is Curly's line C, and the black arrowhead is Curly's line B, okay? So one is because of lymphatics, one is because of interlobar septa, and the third one is because they are cut head on. So they are unfaced. That's the word you have to use. Make sense?
Yes.
Yes or no?
Yes, sir. Yes, sir.
Yes, sir.
I should.
Ah,
What is this? What is this? And you have to write 2 or 3 points about this. Any 2 points are okay. Write 2 points. What are you seeing in front of you? What is the syndrome? And write 2 points about the syndrome. in the exam, if you see this, it's very classical. Yes, no, okay.
Yes, sir.
Okay, this is the Klippel-Trenaunay syndrome. Okay, Klippel-Trenaunay syndrome. Usually it's congenital condition characterized by port wine stain, secondary to cutaneous capillary hemangiomas, can present with soft tissue and bony hypertrophy. There can be venous malformations and lymphatic abnormalities, usually limited to one limb. And most likely the cause is absence of a deep venous system, can also cause congenital AV fistulas, can cause varicose veins, and cause hypertrophy of the involved extremity. So you should have written 1 or 2 points to get the extra mark. Okay, if you've written a couple of points, you get 1 extra mark. If you have not written anything, you get no marks for that. If you've identified the name right, you get 1 mark. So 2 marks in this question. Okay. So it's a congenital port wine stain. That's what it's called as. Cutaneous capillary hemangiomas with soft tissue and bony hypertrophy, venous malformation and lymphatic abnormalities, usually limited to one limb, causes absence, usually due to absence of deep venous system, may cause congenital atriovenous fistulas, may cause varicose veins, and hypertrophy of the involved limbs. Okay? Happy or not happy? Shri Krishna, are you still there? Is it making sense for these
Okay,
guys?
sir. Okay, sir.
Okay. Give me the name of the pathology. One mark for name of the pathology.
Yes, sir.
Okay, it's Temporal Pentalogy. Okay, that's what this is called as. We discussed this last time. Diaphragmatic hernias, cardiac abnormalities, omphalocele, absence or malformation of the pericardium, and sternal cleft. Those are the 5 things that are there in this Temporal Pentalogy. Okay. What are you seeing in the echocardiogram? There are some arrow marks there. What are you seeing? And what does it cause? In 3 views, you can see this pathologies. These are called as Lambel's excrescence, okay? And is small filiform or laminar lesions on aortic valve, first described in 1856, prevalent in healthy controls as well, okay? So it's not a pathology, okay? And is not associated with congenital venous disease and are not associated with pathogenic risk factors. Some people, you should treat these as infective endocarditis. So it's very important to know that these are normal structures which may be present. Okay. All right. Tell me, what is this test? What is this test? What am I describing?
Yes, sir.
Okay, this is the student's t-test. Okay, all right, thank you. What is this test? Oh, it's come up. So we take away. Tell me, describe this test. What conditions do you, I forgot to take away the top. So in which condition do you do this test? Give me 2 conditions where you would do this test. Or 1 condition at least. To get the 1 mark, you have to tell me 1 condition where you do Tinels test, Tinels sign. How do you elicit Tinels sign? Okay, it's a sensation of tingling or pins and needles felt in distal extremity when percussion is made over the site of an injured nerve. Okay. The important thing about Tinels thing is it is not a transaction. It indicates a partial lesion or early regeneration of a nerve. And specifically, it's done when you are talking about carpal tunnel syndrome or you're talking about thoracic outlet syndrome. Okay, so in thoracic outlet syndrome and in carpal tunnel syndrome, you can do a Tinels test. Yeah, to identify if the nerve is partially damaged or if there is regeneration of the nerve. What is happening here? Describe the syndrome or describe what is happening. People who are specifically doing thoracic don't get disheartened. There's a lot of thoracic coming. I've mixed it all up so that everybody will be interested. But even people who are doing thoracic need to know some of these. Okay. What is this? Okay, it's a Stokes-Adams attack. Okay. Stokes-Adams or Adams-Stokes syndrome. Okay, both are things. So Stokes-Adams is fainting spells associated with complete heart block or other types of bradycardia. Now, a lot of people who go for FRCS exams don't read this particular part of the exam. And this is actually, I know that cases are kept in the exam with this pathology because they sometimes do have intrathoracic issues. What is the sign that is being done? Most people forget to read about this pathology. What is the sign being done? Because very often this pathology is also lands in the hands of a thoracic surgeon. What is the test that is being done?
Yes, sir.
This is the Mobius sign. Now, for 1 more mark, describe the pathology in which you do the Mobius sign. You try to elicit. So describe how you do it and what is the pathology.
Yes, sir.
It's a sign of Graves' ophthalmology. Okay. So this is failure of ocular conversions following close accommodation at a distance of 5 inches. So you move your finger in front of the patient's eye and the patient is unable to converge the eyeballs inside. And usually seen when you got a large thyroid goiter, okay, or Graves' disease as it is called as. Please, if you're going for FRCS exam, you must read about thyroid. Very often, most people forget to read about thyroid. So I want you to read about thyroid because a case may be kept because you can get retrosternal goiter or it will come in the x-rays and radiology, and we will discuss the eye signs of Graves' disease. It's very important to know this, okay, for the exam. I've known a long case kept in the exam for a retrosternal goiter. Okay, what is the fiber that we are talking? I'm talking about only this one, atriofascicular tract. Forget everything else, just look at this one. Which is this fiber? The atriofascicular tract. What is it called as? Some you may not know, it's okay. Don't worry about not knowing an answer. The whole idea of today is to learn. So this is called as Brechen-Marchers fibers, okay? Brechen-Marchers fibers are fibers which connect the atrium to the His bundle. Okay, it connects the atrium to the His bundle. They are a type of accessory pathways in the conduction system. You have atrioventricular fibers, which are called as Kent fibers, atriofascicular fibers, which are called as Brechen-Marchers fibers, and nodofascicular fibers, which are called as Maheim's fibers. These three names are important for the cardiac boys who are going to look at ECGs and things in the exam. Very often we will keep ECG in the exam, and you should be able to identify what is happening on the ECG. And at least these three names you must know. Kent fibers, which is atrioventricular, Brechen-Marchers, which is atriofascicular, and Maheim's, which is nodofascicular fibers. Okay, that's why I gave you the picture with all three. What is the test being done? There are two names to this test. It's a sign and a test. What is being done? If you get both right, you get 2 marks. Again, as I said, I've included cardiac, thoracic, and peripheral vascular. So everything needs to be written in this. And thoracic boys who are not giving cardiac exam, you still need to learn a few things in life. So these next 2 hours are not wasted. Name of the sign and name of the test. Yes, no. Carry on, don't carry on.
Proceed, sir.
Proceed.
Proceed, which means you don't know the answer. Okay.
Don't know.
This is Rumpel-Leeds sign or Hess's test. Okay. And Rumpel-Leeds sign is a sign for capillary fragility. Okay. It is carried out by increasing venous pressure in the forearm with a blood pressure cuff and then inspecting the skin for petechial eruptions. It's also called as the Hess's test. Okay. So this is for capillary fragility. When you are looking for capillary fragility, this is the test that you do. The Rumpel-Leeds sign or the Hess's test. What is this? And in which pathology do you use this? What is auramine-rhodamine test? Let me help you. Auramine and rhodamine are dyes. Yeah. Okay, this is a fluorescent staining technique. It is most sensitive for identification of Mycobacterium tuberculosis. Okay. In fact, it's better than Zeal-Nelson's test. Okay. And it's also called a Struent's test for AFB. Okay. So auramine-rhodamine is a fluorescent staining, most sensitive for identification of Mycobacterium tuberculosis. Better than Zedden's staining. Also called a Struent's method for AFB, and this is how it looks like. This is how the AFB looks like when it is put under the auramine-rhodamine staining technique. So this is a staining technique, and you get a fluorescence with AFB. Okay, so this is a special test used for tuberculosis. Okay. Is it going well so far? Is it making sense?
Yes.
Are you guys, is it enjoyable or is it getting
Yes, sir. Yes, sir.
boring?
Definitely, sir.
Yes, sir.
Yeah. Anybody else wants to have any comments? Is this a good way to learn?
Yeah, it's
Different way
fantastic.
to learn? Okay. What am I talking about?
Yes, sir.
Done.
Standard deviation. Okay. This is the definition of standard deviation. It's a measure of spread of score away from the means. What is this? What is Lowenstein-Jensen's medium, and in which disease do you use it?
Yes, sir.
Yes, sir.
Okay. It's a culture medium for mycobacterium. Okay. And this is how the colonies find. So it is a greenish bluish looking colony. And this is how the colonies are formed. This is how they look like. So sometimes in the MCQ, you might get a flash picture of this. Okay. For an LJ medium with mycobacterium colony. This is very classical. For some reason, the next one again looks a repeat of the previous question, but take an extra mark if you can still identify what is this. Give me a name for this test. What is the blue covering? Give me a name. It got repeated from a previous one. I know it got repeated because there are two names for this test. Take a mark. I'm happy to give you a mark if you can identify. You saw this slide earlier. And there are two people who have described this test. Okay. So this is Branham's sign, and also called as Nicolandoni's sign. Okay. Branham's sign or Nicolandoni's sign is bradycardia after compression of AV fistula. What is this disease? Specifically called as selenium deficiency and endemic heart disease. Look at the picture of the patient. Usually happens in China. Selenium deficiency and heart disease. What is the connection? What
Yes,
is the
sir.
name given to this disease? Let's say it's Cation's disease. Okay. Cation's disease is endemic cardiomyopathy associated with selenium deficiency. Okay, it's endemic cardiomyopathy. Okay. What is this slide? There are two names for this. You can get 2 marks if you give me 2 names for what you're seeing. And you can get even an extra mark if you tell me which organism is it looking at. Two names for this sign. And an extra mark if you tell me the organism. Very classic. This is very classic. Microbiology.
Yes, sir.
Done.
Okay, this is called as Draftman's concentric rings. Okay, specifically for Streptococcus pneumoniae. This is a classical sign on culture, Streptococcus pneumoniae, and the other name for it is carom coin appearance. Okay, so carom coin appearance, also called as Draftman's concentric rings, specific for Streptococcus pneumoniae. It is almost diagnostic if you see this sort of appearance on a culture medium. What is this test? You have to describe the test. You have to tell me how it is done, and you have to tell me the disease in which it is done. Describe the test, how is it done, and tell me the disease in which it is done.
Highlighted, sir.
Hey, be quiet, yaar. Whoever is talking, be quiet. Because there are 40 other people who are trying to solve this. Yes or no?
Yes, sir.
Yes, sir.
Okay. So this is done for echinococcus specifically. It's an intradermal test. And the two philosophies that it encompasses is indirect heme agglutation and ELISA. Okay. So intradermal test using indirect heme agglutation and ELISA. And this is what it looks like. Okay. This is a Cassonese positive test where you get a positive reaction to the antigen that you are going to inject intradermally into the patient. What is being done? Describe the sign. There are two aspects to the sign. There's one to the right and one to the left. And describe what is being done. Which condition is this used in, this test? One
Yes,
is
sir.
you're hanging it outside the examination couch, and the second is you're lifting it up. Okay, this is the Burgess sign, okay? The Burgess test. It's in peripheral vascular disease. The red foot becomes pale with elevation, okay? That's the important thing. So there are two aspects to the test. One is the rising of the leg. When you rise the leg, there is blanching caused within 1 to 2 minutes. And then when you lower it outside, it becomes cyanotic. Okay, so the both aspects are part of the test. One is you raise it above the level of the hip to see the blanching, and B, when you hang it down, you see the cyanotic congestion. And this is what it is. This is typical peripheral vascular disease. It's a very important test for identifying peripheral vascular disease. Okay. All right. Go ahead.
Yes.
Next. What? Oh, shit. Sorry. What is this? One mark if you tell me where this is described. What is Runts disease? Okay. This is a disease associated with rejection of transplants. Okay. So associated with graft versus host disease. Specific. Okay. This is specifically for rejection of the graft. And it's allograft in a recipient in whom specific immunological tolerance has been induced. Present with clinical evidence of retardation of growth, diarrhea, hepatosplenomegaly, lymphoid atrophy, anemia, and terminating fatally. This is a rejection of lung transplants, okay? That syndrome is called as Runts disease. This whole graft rejection is called as Runts disease. What is happening here? It's okay if you don't know, all right? But just describe the name of the sign. There is a graph next to it. Describe what's happening on the graph. And the third mark is for clinical condition in which this sign is positive. Actually, this report is showing a positive sign. So describe the sign. I need the name of the sign. I need what is happening on that graph that you're seeing, the upper one. And third question in this, the third mark is for clinical condition in which this sign is seen.
Yes, sir.
Yeah. Okay, this is called as Lancisi's sign. Okay, Lancisi's sign. And what you're seeing there is giant V waves. And the clinical condition in which Lancisi's sign is positive is in tricuspid regurgitation. Okay. All right. So far, so good.
Yes.
Yes, sir.
Is it fun?
Yeah.
It's okay if you don't know. Sorry?
But
Sorry, what are you saying, Vikas?
Slowly it is turning bad now.
What is turning back? I can't hear you.
Performance, sir.
That's okay. This is not about performance. It's about knowledge, improving your knowledge. We're trying to improve your knowledge, okay? And these are all names which are there in cardiothoracic surgery. So that's why I put all this up. It's taken me a long time to collect all this. What is the condition? The clue is in the description there. It's okay if you don't know, because at least you learn now.
Yes, sir.
Done.
Okay, this is called as Kaplan syndrome, okay? So what is Kaplan syndrome? You can get an extra mark if you tell me what is Kaplan syndrome. It's rheumatoid arthritis with pneumoconiosis, okay? And this is actually seen in patients who are in the mining industry. So it leads to this interstitial pulmonary lesions. Okay, you'll get this multiple diffuse pulmonary change in the chest axis. This is a very classical picture of Kaplan syndrome, okay? There are many nodules which have central necrosis, and it occurs in asbestosis and silicosis. And very often when you are dealing with a patient with mesothelioma, you may get an associated Kaplan syndrome seen in the other lung, okay? So asbestosis and silicosis exposure causes what is called as Kaplan syndrome, okay? All right. What am I talking about? If the patient is in fact healthy, how often the test will be negative? Negative in health. What am I talking about?
Yes, sir. Yes.
Yeah, specificity. That's the statistical thing that I'm talking about, okay? Negative in health is specificity. And the way to remember is P. So P is for positive. So the answer is negative. Sensitivity has got N in it. So N is negative. So positive. Positive in health and negative in health, okay? Presence of disease, absence of disease. That's how you remember. What is this? And you will get an extra point if you tell me what is the lowest score and what is the highest score you can get. It's an easy one, but I'll give you an extra mark if you tell me the highest score and the lowest score in this test that you're seeing in front of you.
Yes, yes.
Bhai, khamosh raho na.
Yes, sir.
Okay,
Done.
this is the Glasgow Coma Scale, okay? Can the Glasgow Coma Scale be 0?
No, 3.
Okay, so E, it's eye-opening verbal response and motor response. There is no 0 grading in Glasgow Coma Scale, okay? You have to remember this. There is no 0 grading. Lowest possible is 3 and highest possible is 15. Okay? All right, good, 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 good. Next question, what is this happening? Read through it. Tell me what is happening.
Done.
Okay, this is the Valsalva's maneuver. Okay,
Yes.
all right. What is this tracing? And you get an extra mark if you tell me phase 1, phase 2, phase 3, phase 4. What is this tracing? And an extra mark if you tell me phase 1, 2, 3, and 4. Yes or no? You are all going to kick yourself in the back just 1 second later, because this is actually the tracing of a Valsalva's maneuver. This is a classic description of the tracing of a Valsalva's maneuver. Okay, this is what you see. It was first described in 1704. It has 4 phases. It's a method of expelling pus. That's how it was described initially. It was a method of expelling pus from the middle ear. Deep inspiration followed by forced expiration against a closed glottis for 10 to 12 seconds. There are 4 phases to Valsalva's maneuver. The first phase that you see is a transient rise in blood pressure with straining. Phase 2 is decrease in systemic venous return and blood pressure and reflex tachycardia. Phase 3 begins with cessation of straining associated with an abrupt transient decrease in the blood pressure and in systemic venous return. And phase 4 is an overshoot of the systemic arterial pressure and relatively obvious reflex bradycardia that is associated. So I'm going to go back and show you these tracing. You must know this tracing, okay? Put this in the exam. Also in the MCQ, this might come up. So phase 1, phase 2, phase 3, and phase 4. And you must learn how to interpret what is phase 1. So everything that I described has to be interpreted according to the Valsalva's maneuver. Okay? So this is there in thoracic, cardiac, everywhere. Okay? Phase 1 is transient rise in BP. Phase 2 is decreased in SVR. Phase 3 is abrupt transition, transient decrease in the blood pressure and in SVR. And phase 4 is an overshoot of the systematic arterial pressure. So when you get this graph later on, sit and read through it and try to understand what is exactly happening in the Valsalva's maneuver. Okay, important. This is an MCQ. Comes in many questions. Okay, what is happening here? Describe the test. Number two marks here. One is for giving a name to the test, and the second mark is for telling me in which disease do you use this test.
Yes, sir.
Happy? Okay, this is the Homan sign.
Homan.
Okay? Yeah, the Homan sign is said to be present when passive dorsiflexion of the ankle is a passive dorsiflexion of the ankle by the examiner elicits a sharp pain in the calf. Okay, it is caused by thrombosis of the deep veins of the legs. This sign is frequently elicited in clinical practice because of the ease of the use, although it is falling in disfavor because of the risk of producing an embolism and because it's frequently positive in individuals without DVT. So you have to use the Homan signs carefully. Okay, you might embolize a clot. It is named after American physician John Homans. To test for Homan sign, you have to flex the patient's knee slightly with one hand and dorsiflex the foot with the other hand. The risk is you might actually cause an embolism. Okay, and the complaint of calf pain with this procedure is a positive sign and often indicates venous thrombosis. Okay, so you had 2 marks you could have taken there with either the name or the description of the disease. Okay, and absence of Homan sign does not preclude venous thrombosis. So I'm going to give you 1 extra point. What is the most sensitive test to be used in clinical practice for this disease? An extra mark for that. Answer is duplex. Okay, so duplex scanning is the answer for that. What is happening here? What is the sign? There's a name to this sign. Even if you describe to me what you're seeing on the chest x-ray, I will give you 1 mark. If you describe to me what is the sign, I will give you 1 more mark. If you give me the name of the sign, that's good. This is clinical test, okay, that you do in this condition. It is a clinical test that you do in this condition that gives you a suspicion of what is happening. What are you seeing on this X-ray? Okay, this is called as Hamann sign, okay? Hamann sign is a crunching, rasping sound synchronous with the heartbeat heard over the precordium in spontaneous mediastinal emphysema. Okay, so what you're seeing there is mediastinal emphysema. You can see pneumomediastinitis next to the heart if you look carefully. And also if you look at the lateral film, you can see air in the mediastinum. And Hamann sign is the one that's used to elicit a crunching sign over the precordium. Named after John Hopkins clinician Louis Hamann, the sound is best heard over the left lateral position, and it's precordial crackles. You hear a crackle that correlates with the heartbeat and not with the respiration. The important difference in this is you're actually correlating the crackles with the heartbeat because the air is around the heart in the mediastinum. So the crackles are not associated with respiration, but are associated with the heartbeat, and it is early sign, clinical sign, which will help you to diagnose pneumomediastinum or pneumopericardium. Okay, pneumomediastinum or pneumopericardium, and the commonest commonest disease in which you can get something like a pneumomediastinum or a pneumoperitoneum is esophageal rupture. So next time you see a patient with esophageal rupture, you must put your stethoscope to the precordium and listen for the crackling. The crackling sign in association with the heartbeat gives you an indication that you're dealing with pneumomediastinum or pneumopericardium. Okay? Everybody happy with that?
Yes, sir.
Something new you learned today. Okay. Next question. What is this? Just give me one name. I want either this one or this one. Both are okay. Give me what is happening here or give me what is happening here. Both of them, I'll give you 2 marks for that.
Yes, sir.
Okay. This is Waterston-Cooley shunt. This is Potts shunt. Okay. This other one is Potts shunt. Yeah. Okay. Now, Waterston-Cooley shunt was originally described for treating tetralogy of Fallot. It is an anastomosis of the descending aorta to the right pulmonary artery. So it's a direct anastomosis of the descending aorta to the right pulmonary artery. That was called as Waterston's shunt. And Potts was descending aorta with the left pulmonary artery. So this is right pulmonary artery, this is left pulmonary, direct anastomosis. Both of these are not done nowadays, okay, rarely performed. Okay, so treatment of tetralogy of Fallot as a shunting mechanism, okay? All right, what is this going on? Give me a name. 1 mark if you give me a name.
Okay, sir.
Yeah, this is classic Blalock-Taussig shunt, okay? This is a classic BT shunt. Give me a name.
Yes, sir.
Yes, sir.
This is modified BT shunt. Give me a name. They're all tetralogy of Fallot, but give me a name.
Yes, sir.
This is called a central shunt. Give me a name to the operation. Take your time, look at the operation, give me a name.
Yes, sir.
Yes, sir.
Glenn shunt. Give me a name.
Yes, sir.
Yeah, let other people answer. Some people, this is very difficult for some people. This might be easy for the cardiac boys, but very difficult for others. This is bidirectional Glenn shunt. Okay. Give me a name of the operation.
Yes, sir.
This is Norwood's procedure with a modified BT shunt. Give me a name.
Yes.
This is again Norwood's procedure, but with a Sano shunt. Okay. All right. So let's talk a little bit about the Norwood's procedure. It's used for treating hypoplastic left heart syndrome. It has 3 stages. Step 1 is anastomosis of the proximal main pulmonary artery to the aorta with aortic arch reconstruction and transection and patch closure of the distal main pulmonary artery. A modified right BT shunt, which is subclavian artery to right PA, to provide for pulmonary blood flow. ASD is created to allow for adequate left to right flow. That is the stage 1. The stage 2 is a bidirectional Glenn shunt to reduce volume overload of a single right ventricle. And then stage 3 is a modified Fontan's procedure to correct cyanosis. Again, this is not a lecture on pediatric cardiac surgery. These are all spot diagnoses. Okay. All right. Give me a name for what you're seeing. This is called as facies hypocritica. What does that mean? It's the change produced in continence of death or long sickness or excessive evacuation, excessive hunger and the like. This is the same thing that you would see in cachexia. So it's terminal cachexia. The nose is pinched, the eyes are sunken, the temples are hollow, the ears are cold and retracted, the skin of the forehead is tensed and dry, the complexion is livid, the lips are pedant, relaxed and cold. Okay, it's the death look that you get on the face with chronic malignancy, with chronic starvation or chronic cachexia. Okay, it's the same term as chronic cachexia, but it was described by Hippocrates and it's called as facies hypocritica. Very often in an exam with a CA lung patients or a CA esophagus particularly, patients will have this facial feature. And I asked the student, what is this facial feature called as? And they don't know the answer. The answer is facies hypocritica. Okay, it is there in clinical practice. You will see this in your clinical practice, with particularly with CA esophagus patients. What is this? One mark for naming the sign and 1 mark for describing which disease it is in.
Done.
Okay, this is the Dalrymple sign. Okay, it's widened palpebral eyelid tissue or lid spasm seen in thyrotoxicosis, Graves' disease. Causes abnormal wideness of the palpebral fissure, a retraction of the upper eyelid. The white of the sclera is visible at the upper margin of the cornea. Okay, so the white of the sclera visible is called a Dalrymple sign, and it's a pathognomic eye sign in Graves' disease. Okay. All right. Now you must know all the signs of grave disease. I'll just quickly go through the signs just to help you. And you need to go through these things, okay, for your exam. Everybody who's doing FRCS, certainly please do it. And also MCH may have this exam. So Dalrymple sign we spoke about. Stellwag is rare blinking. Rosenbach is tremors of the eyelid. The Jelinek sign is hyperpigmentation of the eyelid. Okay, quite important. So see these three signs. Stellwag, one is Geoffroy's, we did Mobius. This is the Jelinek sign, where you get hyperpigmentation around the eyes. And then Nafziger's sign, when you look down, you cannot look down the bridge of the nose. Okay, so please go and read eye signs for Graves' disease. Okay, in the examination, you might get a case with eye with the retrosternal goiter. Please be careful about that. Okay. What is happening here? I'm going to take a break for 2 minutes. Okay, just give me a break for 2 minutes. You guys total up your marks and tell me how you're doing so far. Okay, guys, I'm back. Hello? Can you hear me?
Yes, sir.
Okay. How are we doing so far? Anybody wants to feedback? Hello?
Yeah, we are doing good, sir. Yeah.
You're doing good? Okay,
Yeah.
good. I'm happy. Somebody is happy. We will stop at 7 sharp, which is in another 35 minutes. Are you okay? Or do you want me to stop now?
How time went, we didn't know only.
We have done 1 hour and 25 minutes so far.
Yes.
So at 2 hours, we will stop because I've got lots of collection here. Okay, next question. What is this being done? Two marks for this, 1 mark for telling me the sign and 1 mark for telling me which disease. Hello? Yes, no? Continue.
Proceed, sir.
Okay, this is called as Cardiothoracic sign, okay? So Cardiothoracic sign is an abnormal pulsation of the trachea that is found in patients with a dilatation or aneurysm of aortic arch. So you have to actually feel for the trachea, and transmission of pulsation usually indicates presence of an aortic aneurysm, okay? It's one of the subtle signs. So it can be felt by physician by pressing on the thyroid cartilage and particularly displacing it to the patient's left. Because when you move the trachea to the left bronchus gets in touch with the aorta, okay? So this increases contact between the left bronchus and the aorta, and thereby the systolic pulsations from the aorta can be felt at the surface if an aneurysm is present. So you feel the trachea and move it to the left. And when you move it to the left bronchus comes in touch with the aneurysm. And that causes the pulsations to be transmitted up into the trachea. What is this sign? It says tracheal tug. What is the name for that sign? Similar one, similar to the one that I cardialis. This is another name for it, but give me the other name. It's also showing you the diagram of how this happens. The left bronchus touches the aorta. But what is the name for tracheal tug? You get a tug or a pulling. Okay, that's called as Oliver's sign. Okay, tracheal tug or Oliver's sign classically present in aortic aneurysm. Pulsation of an aorta felt through the cricoid cartilage when the chin is elevated. That is Oliver's sign. Okay. So this is an abnormal movement of the trachea during systole that indicates dilatation or aneurysm of the aortic arch. So let's just go through it. Okay. What is this? What is this syndrome? Okay, it's a failure of the third and fourth pharyngeal pouch to differentiate into the thymus and parathyroid gland. There are facial abnormalities resulting from abnormal development of the first star. The classical thing is 22q11. So this is called as catch-22. Okay, the catch-22 is it is always associated with cardiac abnormalities, abnormal facies, the T cell deficit owing to thymic hypoplasia, a cleft palate, and a hypocalcemia. Catch-22. Sometimes an MCQ may come with catch-22 written on it. If catch-22 is ever mentioned, you must call it D. George syndrome. Okay, 22 is the deletion of the gene, and C is the congenital cardiac abnormalities that you get with it. So remember this word catch-22. Okay, so this is what it is. This is how the kid is, and cardiac abnormalities, abnormal facies, thymic aplasia, cleft palate, hypocalcemia, or hypoparathyroidism, always associated because of the first cleft not joining well. Okay, so remember the word catch-22. I specifically brought this because there is an MCQ in the lot which talks about catch-22. Okay, and that's D. George syndrome. Okay, what is this? Again, this is directly from an MCQ. One mark for describing what it is and one mark for telling me what else is associated with it. So this is keratoconjunctivitis sicca, okay, dryness of the mouth and eyes. And this is usually affects the salivary lacrimal glands, but also present with interstitial pulmonary fibrosis. So when we take lung biopsies, we have to think about Sjogren's syndrome for interstitial pulmonary fibrosis. That's why I brought it to the table. And it is associated with lymphoma. So that's the important thing. It is sometimes with lymphoma, when you do a biopsy of a mediastinal lymph nodes, the histopathology may come back as Sjogren's syndrome. So in that situation, you have to go back into the lung and biopsy the lung as well. Okay, and this is the classic association of Sjogren's syndrome. But the eyes and the feet are the most important thing. Okay, so keratosicca is what it's called as. Okay, what is this triad? In the ICU, you look for this. This is again from an MCQ. That's why I bought it here. It's a sign used to look for increase in intracranial pressure, rise of systolic blood pressure, decrease in the pulse, and decrease in the respiration. It's a sign telling you that ICP is raised. What is it called as? Cushing's triad, okay? That's the name given to this. So Cushing triad is a sign of increased ICP. 1 is hypertension, 2 is bradycardia, and 3 is irregular respiration. This sign is seen in the ICU when you have got raised ICP. Okay, what is happening here?
Yes, sir.
Name of the sign and what condition it comes in. 1 mark for each. So this is Lytton sign, okay? And Lytton sign is diaphragmatic movement seen on one side, but not on the other in unilateral phrenic nerve palsy. Okay, unilateral phrenic nerve palsy. Important to learn this. Okay, what is happening here? Classically seen when you raise your hands. So you have to tell me what is the name of this sign and what is the clinical condition in which this sign is positive. Yes or no?
Yes, sir.
Yes? Okay, this is the Pemberton sign, okay? Now, Pemberton's sign is in SVC obstruction. So there is development of facial plethora, inspiratory stridor, and non-pulsatile elevation of the JVP when the patient lifts arm over the head. For thoracic exam, this will come for sure. So Pemberton sign is in SVC syndrome, okay? SVC obstruction. So you saw the picture, very classic. The face becomes flushed, okay? And then the JVP is raised. So there is a non-pulsatile elevation of the JVP, okay? So that's quite important. And patient has inspiratory stridor because the SVC, because whatever is obstructing starts to obstruct the airway as well. Okay, what is this sign? Clinical condition in which you see the sign and what is the sign? 2 marks. Yes or no?
No idea, sir.
Okay, it's an aortic regurgitation sign, pulsation of the spleen. So when you have splenomegaly and aortic regurgitation, you get pulsatile expansion of the spleen. Is a diagnostic peripheral sign of aortic regurgitation. What is this? Name of the sign and clinical condition.
Yes, sir.
Okay, it's the Corrigan's pulse, okay, seen classically in aortic regurgitation. A rapid and forceful distension of the arterial pulse with a quick collapse. Okay, also called as water hammer pulse. Okay, you see this jetting of the thing, rapid rise, rapid fall, rapid rise, rapid fall. What is this? Name of the sign. Name of the sign.
Yes.
Yes, sir.
Okay, Dermoset sign seen in aortic regurgitation. Name of the sign.
Yes, sir.
Muller's sign, okay? Pulsation of the aorta, very classic. Pulsation of the uvula, secondary to aortic regurgitation. Name of the sign.
Yes, sir.
Quincke's sign, okay? Capillary pulsation seen on light compression of the nail bed, okay? So it's same thing that you're seeing in the uvula, similarly you get a regurgitation sign. Name of the sign.
Yes, sir.
Pistol short femorals.
Yes.
Eponym. Give me the eponym. Prob sign. Okay. Give me the name of this sign. All of this is an aortic regurgitation. If you've read it, you get 1 mark very easily. Gradual pressure over the femoral artery leads to a systolic and diastolic bruit. What is the name of the sign? In aortic regurgitation again. Yes or no? Durozius sign, okay? This is called a Durozius sign. Name of the sign. Popliteal systolic blood pressure exceeding brachial systolic blood pressure 60 millimeters of mercury or more. It is the most sensitive sign for aortic regurgitation. Take a blood pressure in the limb, take a blood pressure in the arm, and if there's a difference of more than 60 millimeters of mercury, it is a positive sign for aortic regurgitation. Yes. But what is the name of this sign? Yes or no?
Can't recollect, sir.
Yes, sir. Yes, sir.
Can't recollect is 0. Okay, it's called as the Hills sign. Okay.
Sir, I don't know.
It's okay. Thoracic guys, don't worry about it.
Yes.
At least something you're learning. So there are a lot of signs of aortic regurgitation. If you ever give FRCs, you'll need to know all this. It's mandatory. Pulsation of the cervix in aortic regurgitation. All the cardiac boys should know this by heart, but they don't, unfortunately.
Yes, sir.
Okay, it's called as the Shelley sign, okay? Hepatic pulsations in aortic regurgitation.
Yes, sir.
Yes, sir.
Rosenbach's sign, okay? Okay, visible pulsations of the retinal arterioles in aortic regurgitation.
Yes, sir.
Becker's sign, okay? Pulsation of the spleen in the presence of splenomegaly. Parth, you should be able to answer this now. Come on. First you said you don't know. Now you know. I've repeated it for you.
Yes, sir.
It is the same. Sailor's sign, also called as Gerard's sign. Okay? I just told you Sailor's sign. All right? So this is the way you learn. Okay,
Yes.
a decrease in diastolic blood pressure of 15 millimeters of mercury when the arm is held above the head. What is the name of the sign? Aortic regurgitation. You're supposed to have read this for exam, man. Come on. Main sign, okay? And the last one, systolic contraction and diastolic dilatation of the pupil. Eponym. Don't worry, Nikhil. This is
Yes,
not
sir.
very. This is Landolfi's sign, okay? Now see this video. See this video and you will learn a little bit. Can you see the video?
Yes. Yes, sir.
Okay. Shit, I'm sorry. Question has gone useless because I've shown you the name. So tell me the three things that are associated with this. Three things which are associated with the Furcow's triad.
Yes, sir.
Okay. Predisposing factors in thrombus formation, endothelial injury, hypercoagulability, and stasis. Okay. Or turbulence. Both of them. This is called as Furcow's triad. Yeah. First described in 1860 by Furcow. What is this? 1 mark if you tell me what is this.
Yes, sir.
Factor 12. Okay, factor 12 is called as Eggman's factor. Describe this. And what is the cardiac abnormality you see in this? Is there a cardiac abnormality you see in this? You have to describe that.
Yes.
This is a collagen vascular defect, okay? There are 10 different variants. It's usually characterized by hyperextensible skin and hypermobile joint. The main cardiac defect is mitral valve prolapse, okay? Mitral valve prolapse and mitral regurgitation. That's quite important. So it is an association of Ehlers-Danlos loss with the mitral valve prolapse and mitral regurgitation. You need to know that, okay? So this is how you test for hyperextension. What is this? You have to first tell me where you see this syndrome and 3 important biochemical problems that happen with this syndrome. And this is, I think I gave you this even in one of the MCQs, if I'm not mistaken. This comes in an MCQ for sure. I've read this MCQ. What is this? Where do you get refeeding syndrome? And 3 important metabolic disorders that you get. I think I'll just do 1 or 2 more and then we'll stop. Okay. Yes or no?
No, sir.
No, okay. So the 3 metabolic disorder is hypokalemia, hypomagnesemia, and hypophosphatemia seen in refeeding a starved patient, particularly when you start TPN. So this comes in chylothorax and in other esophageal surgeries and things. When you start refeeding a patient, or you start a patient on TPN or a patient in an ICU, when you start refeeding, you get these 3 things: hypokalemia, hypomagnesemia, and hypophosphatemia. Okay. So just 2 or 3 more I'll do now. 3 more. Okay. We're almost getting there. I've got 360. 365 and I've only reached 150. So I'll do 3 more. Tell me what is this?
Yes, sir.
1 mark for telling me what it is, the name of it. Okay, this is Mobius type 2 AV block. Okay, it's a 2nd degree block with intermittent conduction failure with sudden non-conductive P wave with progressive prolongation of the PR interval. Okay, so non-conductive P wave and progressive prolongation of the PR interval is Mobius type 2. Not seen with digitalis excess or inferior wall MI, but generally seen with anterior wall MI. Okay. Now the last one I'll ask you, what is this? There is some change in the border of the structure, but no change in the lumen. Last question for the day. What is it? Yes or no?
No, sir.
This is monkey buzz arteriosclerosis, okay? Monkey bugs, this is very classical. It is a ring-like calcification within the media of medium size or small muscular arteries. It usually affects the femoral, tibial, radial, ulnar, and genital arteries. Can occur in patients over 50 years. The most important thing is it does not narrow the lumen. It is different from atherosclerosis. Okay, it's completely different from atherosclerosis. All right, thank you very much, guys. I will stop here. I'll stop sharing. We've got at least 150 more. Let me just close it. And there's the recording button.
Enjoyable, sir.
Now tell me whether this session was worth it. Did it make
Enjoyable.
Was it different?
Yeah.
Feedback.
Rapid fire round it was like.
2 hours of rapid fire, but I think it is a good way to learn.
Yes.
Yes, sir.
Absolutely,
More
sir.
than more than 60% are correct, sir.
More than 60%, if they are correct, you have passed the exam. My cutoff for passing was 60%. I expected 60% pass. There are some
Sir,
chance-
this happened because I got most of the AR questions correct.
Very good.
Yeah.
Excellent.
Yeah.
Okay. All right. All right. So give me a feedback. Tell me what is happening. I've got 150 more. If you want, I can do tomorrow as well. Do you want me
Yes,
to
sir.
do tomorrow?
Yes, sir, definitely, sir. Please,
I
sir.
think we have to stop
Yes, sir.
now because this becomes too much otherwise.
Tomorrow we
Yeah,
can
yeah.
do, sir.
Tomorrow we can do the remaining part.
Yeah, this is a good way
We'll
to
keep-
learn. I'd say.
Keep us stimulated to study.
Yeah, the important thing is to go back and revise because these are all spot diagnoses. It's not difficult. It's just spot diagnosis. And this is stuff which can come in the exam. So short cases and all you can get. Particularly the aortic regurgitation is quite easy. The other one that I want you to read is eye signs for thyroid. Don't forget that. Don't go into the exam without reading the eye signs. A lot of people forget about it because they think it's a thoracic exam or a cardiac exam. They don't look at that. So don't forget that. Okay. Now, tomorrow will be a lot more thoracic. I've got a lot more thoracic at the end. But I'm cardiac and I also put thoracic. The thoracic people would have done badly today, probably because they don't know much about the cardiac question and answers. But it's okay. It's all a learning process. Okay. All right. Thank you very much. How's the MCQs going?
Good, it's good, sir.
Are you getting correct or not correct?
Yes.
Are you guys getting better at it?
Yes, sir.
Yes, sir.
Okay. Now, over the period of last 2 weeks or so, I have been on a hunting troll. So I've got more than 1,000 MCQs, which I can share with you guys one by one. But it's a good practice session. It's worth that. I have to say, I have studied more than any of you have.
100%.
This lecture took me about 3 days to make. Okay, 3 days, morning to evening. So it's not easy. It takes a long time to get all these things. But it's a
Very
different
much
way
useful,
of.
Very
Sorry?
different, sir. Very different way, sir. Very useful to us, sir. All the
Yeah,
exam
it is
going.
more fun, and less stress. You mark yourself. I'm not here to humiliate you. I'm just here to teach you.
Thanks a lot, sir. Thank you very much, sir.
All right. Swaminathan, you must share your case with everybody tomorrow or something. It's just a very nice case you showed me.
Sir, which one, sir?
Did you share or somebody shared a case with me earlier? I don't know, maybe not.
Somebody else, I think, sir. Yes.
Somebody else must have shared. Somebody shared a case with me, so I told them to share it with the group.
Okay, sir. Okay, sir.
Okay, all right. Thank you very much, guys. Good night.
Thank you, sir.
Thank you, sir. Thank you,
Are
sir.
the cardiac
so much.
boys also
Bye.
logging? Are the cardiac people logging in as well, or is it only?
No, sir. Yes, sir. Lot of cardiac boys.
Lot of cardiac.
sir.
Yes, sir.
I think
Today we'll
mix it back.
please share with a lot of juniors on the groups. Tomorrow, if they come in, they will learn a lot because there is. This is quite an interesting way to learn, and spot diagnosis. I mean, a lot of things you might not know. Monkeybugs, arteriosclerosis. I mean, I'm pretty sure if I give you that histology slide, you will not be able to diagnose. Or the various signs and all. They're quite interesting. Okay.
Yes, sir. Many first time, many things, sir. First time I'm seeing, sir. Like.
Yeah, and the thing is, you read in the books, but they don't register.
Yes,
So
sir.
once I show you the picture, hopefully a lot will register with you guys.
Yeah.
Okay.
Yes, sir. Yes. Thank you, sir.
Thank you very much. Okay, good night.
Good night, sir.
Thank you, sir. Thank you. Good night, sir.
Good night.
Thank you, sir.